Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a patient comes to the emergency department with sudden double vision, a droopy eyelid, and one eye sitting down and out. The first thought is third nerve palsy, but the urgent clinical question is not just, is this a third nerve palsy? The urgent question is the pupil involved, and could this be an aneurysm? A third nerve palsy means impaired function of the oculomotor nerve. The oculomotor nerve supplies most of the extraocular muscles, the levator palpebrae superioris, and the parasympathetic fibers that constrict the pupil and help with accommodation. So when the third nerve fails, the patient can develop ptosis, diplopia, a down and out eye, and sometimes a dilated, poorly reactive pupil. Before going into the pathology, let us first understand the anatomy, because the anatomy explains almost every clinical feature and almost every exam question. The cranial nerves leave the brainstem in a very organized way. The third and fourth cranial nerves are related to the midbrain. The fifth cranial nerve comes from the pons. The sixth, seventh, and eighth nerves are around the pontomedullary junction. The ninth, 10th, 11th, and 12th nerves are related to the medulla. This is useful because if a third nerve palsy is accompanied by long tract signs, ataxia, tremor, or altered consciousness, you should immediately think of a lesion in the midbrain rather than an isolated peripheral nerve problem. The third nerve nucleus lies in the midbrain. From there, the fascicles pass forward through the midbrain and exit on the anterior surface of the brainstem in the interpeduncular fossa. Then the nerve passes through the subarachnoid space near important arteries at the base of the brain, especially close to the posterior communicating artery. This is why a posterior communicating artery aneurysm is such a classic and dangerous cause of third nerve palsy. After that, the third nerve enters the cavernous sinus, runs in the lateral wall of the cavernous sinus, and then enters the orbit through the superior orbital fissure. Inside the orbit, it supplies the medial rectus, superior rectus, inferior oblique, and levator palpebrae superioris. It also carries parasympathetic fibers to the ciliary ganglion, and from there to the sphincter pupillae and ciliary muscle. So think of the third nerve in four anatomical segments: midbrain, subarachnoid space, cavernous sinus, and orbit. This simple map helps you localize the cause. Now let us connect the anatomy to the clinical signs. Ptosis occurs because the levator palpebrae superioris is weak. The patient's eyelid droops, and sometimes the ptosis is so complete that it actually hides the diplopia. The eye becomes down and out because most of the muscles that move the eye are supplied by the third nerve. When the third nerve is weak, the lateral rectus, supplied by the sixth nerve, pulls the eye outward, and the superior oblique, supplied by the fourth nerve, pulls the eye downward and inward. The net result is a resting eye position that is classically down and out. Diplopia happens because the two eyes are no longer aligned. The patient may describe double vision that changes with gaze direction. But remember, if the ptosis is complete, the patient may not complain of diplopia because the affected eye is covered by the drooping lid. Mydriasis happens when the parasympathetic fibers are affected. The pupil becomes dilated and poorly reactive, and accommodation may be impaired. This is a key clinical clue because the parasympathetic fibers run superficially on the outside of the third nerve. External compression, such as from an aneurysm, tends to damage these superficial fibers early. Microvascular ischemia is different. In diabetes or hypertension, small vessel disease affects the central vasa nervorum of the nerve. Because the pupil fibers are more superficial, they are often spared. That is why a diabetic microvascular third nerve palsy is classically pupil sparing. MRCP trap. Pupil sparing does not completely exclude an aneurysm, especially if the palsy is partial, painful, progressive, or atypical. This is why many neuro-ophthalmologists now recommend imaging all new acquired third nerve palsies, or at least having a very low threshold for urgent vascular imaging. Now let us go through the causes along the anatomical course of the nerve. First, midbrain causes. If the third nerve nucleus or fascicles are affected inside the midbrain, the patient may have a third nerve palsy plus other neurological signs. Causes include midbrain stroke, demyelination such as multiple sclerosis, tumor, inflammation, or compression. A classic midbrain syndrome is Weber syndrome. In Weber syndrome, there is an ipsilateral third nerve palsy with contralateral hemiparesis. The reason is anatomical. The third nerve fascicles are affected on one side of the midbrain, while the corticospinal tract in the cerebral peduncle is also involved. So the eye signs are on the same side as the lesion, but the weakness is on the opposite side of the body. Another related midbrain pattern is Benedict syndrome, where a third nerve palsy is associated with contralateral tremor, ataxia, or abnormal movements due to involvement of the red nucleus region. Claude syndrome is similar but tends to emphasize ipsilateral third nerve palsy with contralateral ataxia. For MRCP, you do not need to memorize every eponym in isolation. The principle is more important. Third nerve palsy plus contralateral long tract signs, ataxia, or movement disorder means a midbrain lesion until proven otherwise. Next, the subarachnoid course. After leaving the midbrain, the third nerve passes close to the posterior communicating artery. A posterior communicating artery aneurysm can compress the nerve and classically causes a painful third nerve palsy with pupillary involvement. This is an emergency because aneurysmal rupture can lead to subarachnoid hemorrhage. Uncal herniation is another important compressive cause. Raised intracranial pressure can push the medial temporal lobe downward, compressing the third nerve. The early sign may be a dilated pupil on the side of compression, followed by ophthalmoplegia and reduced consciousness. So a fixed dilated pupil in a deteriorating patient is not just an eye finding, it can be a sign of life-threatening brain herniation. Now the cavernous sinus. The cavernous sinus is a crowded anatomical space. It contains the internal carotid artery and cranial nerves controlling eye movement and facial sensation. Third nerve palsy in the cavernous sinus is often not isolated. You may also see fourth nerve palsy, sixth nerve palsy, and sensory loss in the ophthalmic or maxillary divisions of the trigeminal nerve. Cavernous sinus thrombosis is a dangerous cause. It may present with fever, headache, painful ophthalmoplegia, proptosis, chemosis, and multiple cranial nerve palsies. Infection can spread from the face, sinuses, or orbit into the cavernous sinus. This is a medical emergency requiring urgent antibiotics and imaging. An internal carotid artery aneurysm within the cavernous sinus can also cause painful ophthalmoplegia. Pituitary apoplexy is another important mimic and cause. This is sudden hemorrhage or infarction into a pituitary tumor. Patients may present with sudden severe headache, visual field defects, ophthalmoplegia, hypotension, or altered consciousness. The urgent management includes steroid replacement if adrenal insufficiency is suspected, along with endocrine and neurosurgical assessment. Tolosa-Hunt syndrome is an inflammatory condition causing painful ophthalmoplegia due to granulomatous inflammation in the cavernous sinus, superior orbital fissure, or orbital apex. It is a diagnosis of exclusion. The pain is often severe, and it may respond dramatically to steroids, but you must exclude aneurysm, infection, malignancy, thrombosis, and pituitary apoplexy before settling on it. Now the orbit and superior orbital fissure. Lesions here can affect the third nerve as it enters the orbit. Causes include trauma, tumor, inflammation, orbital apex disease, and invasive fungal infections such as mucormycosis. Mucormycosis is especially important in patients with diabetes, ketoacidosis, immunosuppression, or hematological malignancy. It may present with sinus disease, facial pain, black nasal eschar, ophthalmoplegia, visual loss, and systemic toxicity. This is a life-threatening emergency. Superior orbital fissure syndrome causes multiple ocular motor nerve palsies because the third, fourth, and sixth nerves pass through this region along with branches of the trigeminal nerve. Orbital apex syndrome includes these features plus optic nerve involvement, so visual loss becomes a major clue. Finally, microvascular third nerve palsy. This is common in older patients with diabetes, hypertension, hyperlipidemia, or smoking history. The palsy is often acute, may be painful, and is classically pupil-sparing. It usually improves spontaneously over weeks to months. But the key is that microvascular palsy should be a diagnosis made carefully, not casually, because missing an aneurysm is catastrophic. So how do we diagnose and investigate? A new third nerve palsy needs urgent assessment. Start with the bedside pattern. Is it complete or partial? Is the pupil involved? Is there pain? Is it progressive? Is it traumatic? Are there other cranial nerve signs? Are there long tract signs such as weakness, hyperreflexia, sensory loss, ataxia, or altered consciousness? Pupil-involving third nerve palsy is an aneurysm until proven otherwise. Painful third nerve palsy is concerning, but pain alone is not specific because microvascular palsies can also be painful. Partial third nerve palsy is also concerning because early aneurysmal compression may not yet produce the full classical picture. Urgent imaging is required when the palsy is pupil involving, painful with concerning features, partial, progressive, traumatic, or non-isolated. Imaging usually involves CT angiography or MR angiography to look for aneurysm, often with MRI brain and orbits, depending on the suspected anatomical level. If there are cavernous sinus or orbital features, MRI with contrast is particularly useful. At the same time, assess vascular risk factors. Check blood pressure, glucose or HbA1c, and lipids. But do not let the presence of diabetes falsely reassure you. A diabetic patient can still have an aneurysm. On examination, look beyond the eye. Test the fourth and sixth nerves. Test facial sensation in V1 and V2. Look for ptosis, chemosis, fever, visual loss, optic disc swelling, and signs of sinus or orbital infection. Examine the limbs for pyramidal signs, cerebellar signs, and sensory changes. A third nerve palsy with contralateral weakness points back to the midbrain. A third nerve palsy with multiple ocular motor nerves and trigeminal sensory loss points to the cavernous sinus or superior orbital fissure. A third nerve palsy with visual loss points towards the orbital apex or optic nerve involvement. Management depends on the cause. If an aneurysm is suspected, this is urgent neurosurgical or neurovascular territory. The patient needs emergency vascular imaging and definitive treatment, usually endovascular coiling or surgical clipping depending on anatomy and local expertise. If there is uncal herniation or raised intracranial pressure, manage it as a neurocritical emergency. The priority is airway, breathing, circulation, urgent neuroimaging, measures to reduce intracranial pressure, and neurosurgical involvement. If cavernous sinus thrombosis is suspected, give urgent broad-spectrum intravenous antibiotics and obtain imaging. If there is invasive fungal disease such as mucormycosis, urgent antifungal therapy and surgical debridement may be needed. If pituitary apoplexy is suspected, give urgent steroids when adrenal insufficiency is possible and involve endocrinology, neurosurgery, and ophthalmology. If the cause is presumed microvascular, treatment is supportive and risk factor focused. Optimize blood pressure, diabetes, and lipids. Give analgesia if needed. Diplopia can be managed temporarily with occlusion, an eye patch, or prisms. Most microvascular palsies improve spontaneously over weeks to months, but lack of improvement, progression, pupillary involvement, or new neurological signs should trigger reassessment and imaging. The key clue is this: a third nerve palsy is not just an eye movement problem. It is a localization problem. The pupil tells you about compression. Associated cranial nerves tell you about the cavernous sinus or orbital apex. Long track signs tell you about the brainstem. Pain is important, but pain does not reliably separate aneurysm from microvascular disease. If you remember one thing, remember this: a painful pupil-involving third nerve palsy is a posterior communicating artery aneurysm until proven otherwise. Quick recall. A 62-year-old man with diabetes develops acute ptosis and a down-and-out eye, but the pupil is normal. He has no other neurological signs. What is the likely mechanism, and what is the trap? The answer is microvascular ischemia of the central vasa nervorum, causing a pupil-sparing third nerve palsy. The trap is assuming pupil sparing always excludes aneurysm. Atypical, partial, progressive, or uncertain cases still need urgent imaging. A patient has a left third nerve palsy and right-sided weakness. Where is the lesion, and what named syndrome does this suggest? The answer is a left midbrain lesion affecting the third nerve fascicles and corticospinal tract, suggesting Weber syndrome, with ipsilateral third nerve palsy and contralateral hemiparesis. Do subscribe to the channel for further videos.